Hello, everyone, and welcome. My name is Isabella Johnson with HPV Cancers Alliance. Thank you for joining us for the very first episode of Season 2 of our Emerging Science webinar series. The topic of today's webinar is Advancements in Follow-up and Recurrence Detection for Anal Cancer Survivors. Before we begin, we'd like to extend a special thank you to our lead sponsor, Naveris. They are a true leader in innovation, advancing technologies that are transforming how clinicians monitor patient outcomes. So we are so grateful to be able to partner on this episode. Naveris also just announced that they were granted Medicare coverage for the NavDX test to be used in the surveillance of patients with previously treated anal squamous cell carcinoma. Congratulations. For those joining us for the first time, the HPV Cancers Alliance is a national nonprofit dedicated to empowering individuals with knowledge about the impact of HPV. Our vision is a world free of HPV-related cancers, and our Emerging Science webinar series helps bring that vision to life by connecting researchers, clinicians, and advocates to share the latest innovations in care. With that, it's my pleasure to introduce our moderator, Taylor Kelamis, and our featured panelist, Dr. Corbin Jacobs. Starting with Taylor, she is a family nurse practitioner and founder of Luna Wellness, a practice specializing in anal dysplasia and cancer prevention. With a background in primary care, public health, and surgical nursing, Taylor focuses on HPV-related disease, STI education, and high-resolution anoscopy. A Peace Corps alumna and graduate of Johns Hopkins and Georgetown, she is an active member of IANS and serves on the board of the Arkansas Nurse Practitioner Association and our very own HPV-CA Scientific and Medical Advisory Board. Moving to our featured panelist, Dr. Corbin Jacobs. Dr. Jacobs grew up watching his mother valiantly battle colorectal cancer for 24 years. She is his inspiration for becoming an oncologist. He attended UT Southwestern Medical Center, where he graduated top of his class and received his MD with distinction in research. Jacobs later completed specialty training in radiation oncology at Duke University. He is board certified and completed additional gamma knife radiosurgery training at the University of Pittsburgh. Dr. Jacobs has been a first author on over 20 peer-reviewed publications and presented his research at a variety of national and international conferences, earning multiple awards. Since completing his training, Dr. Jacobs has continued to mentor medical students and contribute to medical research, including participating in multi-institutional, prospective, and retrospective registries, and being a co-author on multiple HPV-related cancer publications, demonstrating the clinical utility of Naveris' circulating tumor DNA. He is currently practicing in a multi-specialty oncology group called Cancer Care Northwest at their Post Falls Clinic in Northern Idaho. Thank you both so much for being here, and I will hand it off to Taylor to open our expert panel discussion. Thank you so much.
Great. Thank you so much. It's a pleasure to be here. We're going to go ahead with the Emerging Science webinar series and dive right into the current epidemiology of anal cancer. As many of you know, squamous cell carcinoma is a rare malignancy. Just 0.5% of all cancers in the United States, distinct from colorectal cancer, and approximately 10,000 and up to 11,000 individuals expected to die from anal cancer in the United States in 2025. Average 5-year relative survival is about 71%. And women experiencing an increased risk of anal cancer overall, though those that are immunocompromised, living with HIV or solid organ transplant recipients also are at higher risk. There's a very strong association with HPV 16, 18, and some other oncogenic subtypes. The anal canal anatomy is such that it is primed for the HPV virus, the squamo-columnar junction, where the rectal columnar cells meet the squamous epithelium, are the part of the anatomy of the anus that truly is affected most from the virus. And then with some cases leading to precancers and then some more of those leading to malignancy. And that susceptibility of that squamous epithelium to the HPV-driven dysplasia within the transition zone of those two tissues really creates this query for us in terms of our work within the anal canal. It's such a small part of the body and such an important part of the body. And I imagine we can all agree that sphincter preservation is quite important all along throughout the trajectory, whether we are treating anal dysplasia and then, if need be, cancer. So that sphincter function, preservation, and maintaining the quality of life of the patient. And then moving on to anal cancer incidence and trends. As we mentioned, women at higher risk, typically diagnosed after 50 in 70s, 60s, 50s, 60s, and 70s, or in earlier populations in those living with HIV and other immunosuppressive states. Some of the more of the risk factors, in addition to immunocompromise, would be smoking. Those people that have had a history of cervical, vulvar, or vaginal dysplasia are at risk. Receptive anal intercourse, because of the unique anatomy of the anus and the anal canal, and that confluence of the cell types make it predisposed to precancer and infection. And then also it's just an efficient route of exposure. More partners that we have, the greater risk for high risk HPV exposure, and then therefore the greater risk of precancerous lesions and possibly risk for invasive cancer. In terms of recurrence patterns and survivor outcomes, the survivor outcomes have fared better over the last several decades with the advent of the NIGRO protocol in terms of staging and treating anal cancer that is in the lower stages, not metastatic disease, with chemoradiation simultaneously instead of going right to an abdominal perineal resection. Has made a big difference in our treatment protocol. And of course, Dr. Jacobs will speak to that. In terms of the importance of access and adherence to surveillance methods, that would be most important, in addition to the actual tools that we're using. Digital anal rectal exam, high resolution anoscopy, or in the first 5 years, utilizing standard anoscopy, proctoscopy, imaging, and then, of course, blood-based biomarkers for surveillance. And then some emerging challenges in early detection and surveillance. Someone described anal cancer or at least dysplasia as whack-a-mole. Anal cancer does recur, and anal cancer or precancerous dysplasias do recur. And so in order to make it an effective surveillance program, time, money, expertise, as well as the patient's, of course, ability to access those surveillance methods, and would all play a role. And with that, I'm going to go ahead and stop sharing my screen and would love to turn it over to Dr. Jacobs for your side of things in terms of surveillance of anal cancer.
Thank you. Yeah, I can speak on surveillance. It's commonly, according to NCCN guidelines, so I practice in the United States. I'm going to be referencing a lot of North American-based practice patterns, specifically within the United States. But we do physical exam, including palpation of the inguinal lymph nodes, and a digital anal rectal exam. And then we also will incorporate potentially more imaging, including CT scans or MRIs, specifically for more advanced disease stages like stage 2 or stage 3. For anybody who gets treated with that NIGRO protocol that you recommended of chemoradiation, there's options of reducing further radiation exposure to the pelvis by doing the MRIs. We do that especially in patients with rectal cancer who choose organ preservation, and anal cancer is no different. We're trying to do organ preservation whenever possible. MRIs are really good at soft tissue delineation. They do have some drawbacks that we'll talk about later. It's important to scan the chest predominantly with a CT. The abdomen could be either way, MRI or CT. It's kind of dealer's choice. And in addition to the imaging, you can do an anoscopy, including the high resolution one you alluded to. And then every so often, we'll also do more extensive endoscopies. For patients where the cancer is predominantly in the rectum, so it's a more rectal squamous cell carcinoma and not completely confined to the anal canal, you may want to do a sigmoidoscopy or at a minimum a proctoscopy. But every so often, we'll do a full colonoscopy as well. All of these procedures get alternated every 3 to 6 months for the first 5 years, especially with physical exam findings and in-person office visits. The imaging is typically on an annual base just for the first 3 years. And then the anoscopy or other endoscopy is usually every 6 to 12 months for the first 3 years. You can kind of tailor it based on the patient's findings and how high risk they are for recurrence.
Wonderful. Thank you so much for that information. What would you say the anal cancer survivors are typically followed? You did mention specific follow-up tests. Say beyond 5 years, what do you recommend?
So beyond 5 years, I offer my patients to continue to see me long term. Some will go back to their primary care providers or stick with just one oncologist. So patients may have a medical oncologist, a radiation oncologist, and occasionally a surgical oncologist, usually a colorectal surgeon. And some may choose just to follow with one. If they do choose to follow with one, most commonly it would be a medical oncologist. One thing I didn't mention with follow-up is they may get regular surveillance labs. That could include just basic blood counts and basic comprehensive metabolic profile, looking at organ function.
Wonderful. Thank you. And are there limits, current limitations, or any limits you have experienced in real world on physical exams, imaging, anoscopy, et cetera, or the other modalities you mentioned?
Yes. One important mechanism of how the radiation works is it damages the DNA inside the cancer cells. And I tell my patients that means it doesn't explode the cells or make them die off immediately. We have to be patient, and the cancer will keep dying over weeks and months. The way I like to describe it is it damages the blueprints within the cells, and then when the cells go through cell division, they will realize they cannot duplicate the blueprints and they cannot give each cell a copy of the DNA. At that point, when they're stimulated to go through cell division, they will commit suicide. So some cells are stimulated to go through that cell division process a week after radiation, and some a month after radiation, and some several months after radiation, and so on. So the radiation is like the gift that keeps on giving, and we have to be patient. There's a slow, gradual response. And as we're doing these surveillance protocols on physical exam, you may still see a tumor remnant. On imaging, you may still see a tumor remnant. And that can make it challenging to know, is it going to continue to regress, or at some point, is there going to be some residual disease that wants to regrow and potentially metastasize? So the prolonged treatment response is definitely a limitation. There's also anatomic changes where we treat fibrosis, especially, and the anal canal, when it gets fibrotic, can be exceedingly painful for patients. It can make it challenging to do uh, an exam without anesthesia in certain instances. Makes it harder to get good visualization and just having limited field of view. Also, a patient's body habitus may make it more challenging to palpate inguinal lymph nodes in particular. The experience of the provider is important. So anoscopy, especially the high resolution one, requires some dedicated expertise. You would be much better at it than me. And for certain patients in certain geographic locations, they may not have access to someone with that expertise. Also, with the MRIs, I mentioned there were some limitations. One of those is motion artifact. If a patient's in pain or if they struggle with claustrophobia, they may not hold still. They may get sub-quality pictures. There can be sometimes indeterminate findings as the fibrosis settles in and trying to determine what is residual disease and what is just expected post-treatment change. PET scan is not necessarily part of the surveillance protocol, but it is commonly ordered to try to clarify these indeterminate findings. But even PET has its limitations. As someone's still healing from radiation, there may be persistent low-level FDG avidity, and that inflammation and ongoing healing can make it challenging to distinguish what might be residual disease and what is post-treatment change. And then patient compliance is a big factor. If the patient doesn't show up for their appointments or their scans or their procedures, then it's hard to do any form of surveillance. All of these things we've talked about have medical costs and possible financial toxicity to patients, especially if they've already paid a lot for the treatment itself. So all of these have many limitations and unfortunately a high chance of getting some indeterminate findings.
Well, it sounds like it's not pretty cut and dry, is it?
That's
And
right.
while you have many tools at your disposal, there's a lot of gray
That's right.
in that. So, and I love to hear how, focused you are on, the patient modifiable things in terms of, or at least the ones that are dependent on, like you said, adherence, access to, follow-up, but also body habitus and claustrophobia, that kind of thing. So some of those things are modifiable, but some are not. So
Correct.
in terms of the field evolving, do you see this field evolving in a way of detecting recurrences earlier and more precisely?
I do. So one of the exciting things is using circulating tumor DNA, and that can be a personalized tool to help hopefully identify if the patient is in a subgroup of a rapid clearance of their disease or if they have either some residual or progressive disease. Um, Oftentimes, the rapid clearance group can be identified by a simple blood test from a variety of commercially available tests, whereas that complete clinical response we discussed could take weeks and months to sort out. In one study that I was a co-author on, published in the journal Cancers earlier this year, it had a median lead time of 59 days that if someone was going to end up having a recurrence, you would find it on a blood-based circulating tumor DNA test.
That is pretty amazing. Um, could you speak to the growing role of the molecular and biomarker-based testing, such as HPV DNA assays?
Yes, I can. So there was a systematic review published last year. Um, they highlighted 7 articles, and there's more continuing to come out. But that's where they discussed there's definitely a prognostic role where you can identify a rapid clearance group that generally has a better outcome versus those with persistent or early recurrence of circulating tumor DNA that have a worse prognosis. An exciting study that was presented at ASCO GI this year involved Natera's Signatera circulating tumor DNA. This study was 88 patients with a median follow-up of 18 months. And the authors report that for those who cleared their circulating tumor DNA midway through treatment, none of them developed local regional recurrence. And at the 1 year mark, the progression-free survival was 100%. Whereas those who still had persistent positive circulating tumor DNA at mid-treatment had a 26% chance of local regional failure and a 1 year progression-free survival of 81%. And those who at the end of treatment or any time thereafter had detectable post-treatment circulating tumor DNA, the local regional failure was 61%, corresponding to a 1 year progression-free survival of 44%. So among patients who achieved circulating tumor DNA negativity, but subsequently developed molecular recurrence during the surveillance period, every single one of them developed disease recurrence. And the molecular recurrence definitely predated the clinical and radiographic recurrence in all of those instances. What's nice about circulating tumor DNA is it is accessible. So for patients who have certain problems or maybe that geographic inability to get to a center of excellence to do good anoscopy, they can get mobile phlebotomy and just have easier access to this tool. And this tool is independent of post-treatment anatomic changes. So you don't have the same restrictions of fibrosis and pain. Speaking about another blood-based assay, this one is specifically by Naveris, our sponsor. They use a tool called NavDX. And on that article that I mentioned earlier, that was published earlier this year, the sensitivity of NavDX was 85%. The specificity was 99%. The positive predictive value was 98%. And the negative predictive value was 95%. So it is a great tool.
That you took the words right out of my mouth. I was going to ask what stands out about new technologies such as NavDX, the test that you said from our sponsor, Naveris.
Yeah.
You said it already. Are there other things or in addition that you'd like to comment on that?
Yes, so there was a press release earlier this week, and Medicare is now going to cover NavDX 4 times a year for the first 3 years after treatment. And then thereafter, in years 4 and 5, they'll cover it twice a year. Also, there's some unpublished data that we are submitting for publication showing that there are a lot of clinically indeterminate findings with some of the tools that we've discussed. There were 17% of scans that had indeterminate results. 7% of physical exams had indeterminate results, but only 1.3% of all NavDX tests had indeterminate results. And NavDX was able to accurately predict the disease status, whether someone truly was in remission with no evidence of disease, or if they truly had residual or progressing disease in 92% of patients. And for those who had a positive NavDX test, it had 100% concordance. And in this subgroup of a smaller patient population, specifically with clinically indeterminate findings that you're more likely to keep a closer eye on because you're not sure if they still have disease, NavDX still had a lead time advantage of 29 days over the other tests. So it's great. It doesn't replace the need for physical exam. It doesn't replace the need to undergo an annual scan or get an anoscopy, but it definitely complements it. No test is perfect, but based on the kind of specificity and positive predictive value and negative predictive values, this is a very good, reliable tool.
That's fantastic. Sorry for the interruption. I wanted to know kind of you had mentioned how it complements current flows in terms of surveillance, and then also clinically, what impact does that have to have the information 59 days or whatever it is ahead of a clinical known recurrence? What impact does that have for patient care, survival, treatment, et cetera?
Good question. So first I'll speak to how to integrate it into our workflow. It's really easy to integrate it. I can sign off at any given time to order 4 tests for the upcoming year. So I don't have to order it every single 3 months and remember to sign it 3 months down the road. I can just order it once and it can be almost automated. You can schedule something called mobile phlebotomy, and with that, you can schedule a lab draw either at the patient's home if the patient feels comfortable letting someone come to their home, or at whatever local lab is nearby, or in the clinic. So when patients come and see me, I will often have my nurse draw the lab in my office. And then it's really easy to interpret the results. It's in one of 3 categories. It's either negative and undetectable, or on the other extreme, it's positive, and it'll give you a numerical value of what it detects. And then there's a very, very narrow range where it's indeterminate, meaning it's a very low positive, and all you have to do in that setting is repeat a test in a short interval, and it will usually not stay indeterminate. It will usually either move negative or move positive in my experience. As to how it affects survivability, especially if you catch the recurrence earlier, I think that's to be determined. If you catch the local recurrence earlier, I think that is more likely to improve survival. If you catch a distant recurrence earlier, that's where it's to be determined. I personally am a believer of oligometastatic disease and that you can have better outcomes even if you have a stage 4 cancer, if you catch it early and if you aggressively treat all sites of metastatic disease. But that may not be the case with everybody. And maybe what you think is limited metastatic disease that you caught early may just be the tip of the iceberg, and there may be more extensive disease that unfortunately could progress after systemic therapy.
Thank you very much. What are the key considerations for access, equity, and patient convenience using tools like this one?
Yeah. So with access, with that mobile phlebotomy I discussed, it overcomes geographical as well as social barriers. So for patients, I'll share some from my own clinic. I've had patients traveling for a funeral or for a family reunion or a summer vacation or whatever it is. And if they're going to be gone for an extended period of time, I can get their blood draw out of state wherever they are. I have a lot of patients where I practice that choose to go somewhere warmer, maybe more pleasant for the winter. So for those snowbirds, I can still arrange for their blood draws out of state. And then when they are up closer to where I am, then we can get them closer to where we are. But no matter where the patient gets their blood drawn, they all get sent to Navarus. All the results show up on a longitudinal report that makes it very easy to track all the results. For anyone who's sick or maybe doesn't have access to a ride or other social barriers, it's easy to set up a mobile phlebotomy and still closely follow these patients who may have struggles with compliance. And for all of these reasons, circulating tumor DNA testing is very accessible, it's equitable, and it's quite convenient for
Thank
both the
you.
patient and the provider to follow results.
Thank you. And you've previously mentioned that that Medicare now covers the 4 tests in those early years per year, and then twice yearly after for years 3 and 4, is that right?
For years 4 and 5.
4 and
So
5, thank you.
2 years after the 3-year mark.
Thank you very much.
Yep.
How do you approach shared decision-making when discussing new follow-up options with your patients?
So I do my best to educate patients. I try to help them weigh the pros and the cons of different approaches. Some patients will let me know maybe they're losing a job, or maybe they're losing their insurance, or maybe there's some other problem, and we can do our best to come up with a personalized surveillance protocol. I also try to be humble and teachable. I don't pretend to know everything. My patients have come to me and said, "What do you think about this?" And as I do some investigation into it, I can learn about new advances. Actually, I'll share a personal story directly related to our sponsor, Naveris. I treated a patient with oropharyngeal cancer that was HPV related. And when they came for follow-up, they asked me, "What do you think about this test?" I didn't know anything about it, so I called the rep at Naveris. I became educated, and here I am today. And I use it extensively in my clinic. So for anybody who's listening to this, especially if you're a patient, don't be shy about approaching your healthcare provider and asking about a specific test that may not be recommended or not offered to you yet.
That's wonderful. Full circle here. And I love the part about staying humble and being teachable. I think that's excellent, wise advice for all of us. A few audience questions, if we could. What are the signs or some signs of recurrence that I should watch for between follow-up appointments?
Yeah, it's a good question. So change in bowel habits is one, but that can be tricky. You could get more pencil-like stool, possibly even diarrhea, just related to the treatment side effects. But if you're having bleeding or more pain or some other concerning red flag symptom that is a definite new change in your bowel habits, bring that up to your provider. Regarding bleeding, that could also be tricky. Hemorrhoids can be common. Most people, when they're first diagnosed with anal cancer, might have a more delayed diagnosis if they attribute their symptoms to a hemorrhoid. And you're probably less likely to do that a second time once you've been diagnosed with anal cancer. So if you ever think something's a hemorrhoid, get it checked out. If you feel a lump anywhere on your body, if you're having unintentional weight loss, if you get any abnormal labs, so if your primary care provider or some other doctor has ordered labs and say your liver function studies are off or your alkaline phosphatase is elevated, those could be signs of metastasis in the liver or bones, respectively. And then circulating tumor DNA, if you're choosing to incorporate that, should typically precede more concerning symptoms like shortness of breath if you have lung metastases, or neurologic deficits if you have a metastasis that's squishing a nerve, whether it's in the spine or somewhere else in the body. So hopefully we don't get to those dire, bad circumstances, especially if we're using circulating tumor DNA.
Great. Thank you very much. Another question from the audience. Do follow-up plans differ depending on whether I had chemoradiation, surgery, or both?
Sort of. So the biggest difference would be if you undergo surgery, especially if it is not a sphincter preserving surgery, and if you go through an abdominal perineal resection, then you are no longer able to do the anoscopy or the digital anal rectal exam. If you're undergoing a more limited sphincter preserving surgery, yes, you may still be able to undergo those tools. So it really depends the type of surgery you undergo. But aside from that, you can still do inguinal lymph node assessment. You can still do other physical exam procedures. You can still get MRIs, CT scans, PET scans, circulating tumor DNA. So most of the surveillance is similar.
Thank you. I'm sure the audience member is grateful for the response. I have one question about the circulating tumor DNA detecting new incidences of anal cancer alongside recently treated. Does that ever happen, or have you in your practice seen new tumors or lesions pop up not
So,
related to the original cancer?
so to make sure I understood, you're asking not a recurrence of what was treated, but a completely separate, what we would call metachronous anal
Right.
cancer. I personally have never seen that. Um, for head and neck cancers, that is a possibility, but the head and neck oropharyngeal axis is significantly larger. And for a smoking-induced cancer, that's maybe more likely. Could, I guess, also happen for an HPV-related cancer, but I have not seen that in the anal canal area.
Thank you. All right, looking ahead, how might these advances reshape survivorship care in the next few years, in your opinion?
Good question. So one is incorporating more personalized surveillance. So if someone was getting a circulating tumor DNA test, say every 3 months, and it became detectable when it was previously undetectable, that might move up what was originally scheduled. So instead of getting a CT scan or an MRI months down the road, you can obviously move that up. You may also choose to do more close surveillance for someone who didn't clear circulating tumor DNA by the end of treatment. So you can intensify surveillance for certain patients. You may be able to integrate a PET scan earlier. You may be able to identify patients who could undergo a salvage curative intent surgery earlier if they have localized residual disease. What could be exciting and is yet to be determined is if circulating tumor DNA could be a predictive biomarker, either to adapt treatment towards de-escalation or to adapt treatment towards escalation. And I'll share one kind of interesting phase 2 French study that was actually just published 15 days ago. This is in Lancet Oncology, and it enrolled 54 patients with stage 3 anal squamous cell carcinoma. They received induction chemoimmunotherapy. The chemotherapy consisted of 4 cycles of modified docetaxel, cisplatin, and fluorouracil. And the immunotherapy was 3 cycles of a PD-1 inhibitor called ezabenlimab. Never used that one before. After that induction treatment, if patients did not progress, they went on to receive 2 additional cycles of chemo, 1 additional cycle of the immunotherapy. And then their response was assessed by imaging, biopsy of the primary tumor, and HPV circulating tumor DNA. For those who had a major response, which was defined as greater than or equal to 30% tumor reduction on a scan, or who had a pathological complete or near complete response, which means less than 10% viable cells on biopsy, or who had a biological complete response, meaning they had no residual HPV circulating tumor DNA, then that specific group of patients could undergo a de-escalated form of radiation therapy where they would get involved nodal radiation therapy as well as their primary tumor site treated. The dose that was administered for radiation in the other group that didn't have a good response was 59.4 gray. Whereas if they had a good response, there was the option of lowering the radiation dose down to 45 gray, especially if they had a complete radiographic response. You could also omit elective nodal irradiation and just treat the involved lymph node sites at original diagnosis. Now, I do want to say for anybody listening who then wants to go and pursue this experimental treatment that it's not without its morbidity. You're adding in 6 cycles of chemo in addition to mitomycin C and a 5-fluorouracil-based chemo that's typically given with radiation. And you're adding in 10 cycles of immunotherapy because after radiation, it was recommended to get 7 additional cycles of immunotherapy, all to potentially reduce the radiation by 0 to 25%, as well as maybe a smaller radiation target volume. So you have to weigh what you're trading off. There were some treatment-related deaths. There could be some added morbidity, but for these patients with stage 3 anal cancer, the reported results were pretty good, and it's exciting to give personalized, adapted treatment. And this is only one example of many, many possible uses of circulating tumor DNA down the road to either escalate or de-escalate care.
That's wonderful. Thank you for sharing that hot off the press information and study. In terms of that and the potential for certain patients, or at least in this study, to have a reduced dose, would that potentially equal reduced side effects related to radiation therapy or increased quality of life in terms of bowel, bladder, sexual function, pain, etc.?
I would say yes, specifically regarding radiation. For patients who did not get a complete response in that study, they still got the full dose and they'll probably get the same long-term side effects in all the areas you just outlined. Maybe a lower risk of diarrhea and maybe a lower risk of bone demineralization as well as internal fibrosis. But for the clinically relevant side effects, it'll be very similar. If they had a complete response and you could reduce the dose by approximately a quarter, then that would probably improve sexual health, bowel function, and quality of life.
Thank you very much. And
Yeah.
one last question in terms of, again, of looking ahead, what further data or collaboration do you think would strengthen adoption of this technology across cancer centers in the US and abroad?
So specifically within the US, I think once circulating tumor DNA gets integrated into the NCCN guidelines, that will lead to more widespread adoption. I searched within the last 24 hours and circulating tumor DNA doesn't show up anywhere in the anal cancer NCCN guidelines, but I think that will change in the near future. Right now, a lot of the evidence is coming from very small prospective studies or retrospective, either single institution or multi-institutional analyses. But as we get better evidence that gets published, especially with larger sample sizes and more phase 2 and 3 trials, that will strengthen the supporting data and lead to more widespread adoption. And if we can ever get evidence that shows that circulating tumor DNA is not just prognostic, but it is predictive, and you can actually adapt therapy and do more personalized medicine, I think that will definitely strengthen adoption.
Well, that sounds very hopeful and encouraging. So thank you very much. Glad that you, such an expert and passionate about this topic, are really at the helm, not only for anal cancer, individuals undergoing anal cancer treatment, but also head and neck and many others. So thank you for your work. Are there any last minute words that you'd like to speak to before we turn it back to Ella?
Thank you. I just want to say thank you for inviting me to come and share. Thank you to our sponsor, Naveris. And then I also want to thank my mom. She's my inspiration for doing what I'm doing.
Thank you very much, Dr. Jacobs. And Ella Johnson, thank you very much for having me and both of us. It's been a wonderful opportunity, and I'll hand it back over to you.
Of course, this was absolutely amazing. Thank you both so much for participating. It was so insightful and really truly meaningful. And yes, again, a sincere thank you to Naveris and our additional sponsors for their continued support. And this concludes our episode, and we look forward to seeing you again in the new year with a brand new episode of our Emerging Science webinar series, Season 2. So thank you.